Hello, everybody. Thank you for having me. As Camille mentioned, I'm Dave Chmielewski. I'm coming to you live from the Cleveland VA here in downtown. I've been involved in our telemedicine programs here in Cleveland since 2006, actually. So I have been involved in this really from the beginning. When I first started in the program, it was minuscule, and it has reached pretty impressive heights, not only here in Cleveland, but throughout the country. The VA has certainly done a lot to really improve upon telemedicine, not only for our own system, but they've offered a lot of support and guidance to other systems throughout the United States and really even the world. Our original director of the Office of Telehealth Services here in Cleveland, I'm sorry, here in the VA, started telemedicine over in England way back in the day. So we have really been involved since the beginning, and I just wanted to give you a little bit of information on not only myself, but then moving forward, what we're doing, not only what we've done prior to the COVID-19 efforts, but obviously our programs have been something that have been heavily relied on over the past couple of months. And you'll see some of the workload trends that we've had and some of the tremendous uptick we've seen, especially in our video to home world. So just to give you a little bit of understanding about, let me make sure I can progress this forward. There we go. Just a little delayed. There we go. All right, I think there's just a little delay. There, get back one. All right. So just in case you're unfamiliar with our catchment area here in Cleveland, we previously had 18 locations of care. If you've paid attention to the news recently, one of our facilities in the Lakewood, Ohio City area is being closed, more so consolidated. So we have 17 locations of care here in Cleveland, 12 of which are outpatient clinics. Obviously, we have our medical center in downtown Cleveland, 2 community resource and referral centers located in downtown Cleveland and Akron, our psychosocial rehab recovery center here at our Wade Park campus, our dialysis center over on Euclid, which is partnered up with one of our community resource and referral centers, and then our ambulatory surgery center over on Superior Avenue. So you can understand from our catchment area and the number of facilities that we have that telemedicine is something that's very important to us. We have a responsibility, more so than most, to ensure that the veterans that come to our facilities have access to the care they need. So given that most of our specialty care and a lot of our higher level mental health care is only available in Cleveland and Parma, we have a responsibility to not only get it to those individuals at the facilities closest to their home, but also into their home. So the way that we actually go about doing that, here, and this is something that I wanted to pay close attention to here at the beginning, the main reason that I brought this up is up until recently, we were averaging about 128 telehealth appointments per day here in the VA, which is a pretty astounding number, but that included all of our programs. That included our home telehealth program, which we'll talk about briefly on the next slide, our video telehealth program, which includes many different facets, and our store and forward telehealth program for remote image exchange. So keep that 128 in mind as we kind of move forward here a little bit. So as I sort of, I don't know why it's like every time I click something, it moves 2 slides ahead. Our virtual care programs here in Cleveland, up until about 2 or 3 years ago, the telehealth program within VA was considered really the tried and truest. It was the program when it came to virtual care. That particular program was our video telehealth, our home telehealth, and our store and forward programs. Over the course of the last few years, we've added a number of different things under that virtual care umbrella, as we call it now, to include our VA Video Connect program, which is our homegrown internal video to home platform that we offer our veterans and their family members. My Healthy Vet, which is something similar to what a lot of non-VA facilities have, sort of like MyChart at the Cleveland VA. One of the inclusions within My Healthy Vet, beyond being able to review your records and request medication refills and things like that, is the secure messaging functionality with direct conversation with providers, nurses, admin staff, requesting appointments, requesting refills, asking questions. We're about to get into image exchange within secure messaging for patients with dermatology issues or wound issues. Our Scan Echo program, which is provider to provider education. I know a number of areas of our mental health world, our pain medicine world, have Scan Echo sessions that are active not only for providers here in Cleveland, but from providers at other VAs, not only in Ohio, but Michigan, Indiana, Wisconsin, New York. The list really goes on and on. We have a number of different mobile apps, many of which are forward-facing for things like substance abuse. There's a little bit of improvement still to be made on those here within the VA. Most of them right now are really one-directional. It's push information. It's not necessarily pull, so you can't retrieve a lot from patients, but that's something that we're actively working on. And then our point of service kiosks, which is, they're primarily for check-in, and we're not really using them at the moment for obvious reasons. But there's a lot of value that we've had added as a part of those kiosks throughout our system. Just to give you a little bit of an understanding of what some of our platforms look like here. You can obviously, this is VA Video Connect, which is our forward-facing provider to patient, provider to family member, even provider to provider. We've started using this a lot during the COVID-19 efforts to connect individuals within our facility to individuals at other healthcare facilities just to get information. Our home telehealth program has a very strong substance use disorder component built into it. Obviously, at the moment, most of our efforts have been deviated over towards COVID-19, but we still have an active patient population outside of those that are being monitored for infectious disease. I put a nice little picture in here of one of our providers, Dr. Fazal from our East Liverpool clinic, and one of our LPN telehealth clinical technicians, John Knight, engaged with somebody, I don't know where that somebody is, but providing some teleprimary care services. Which I know isn't necessarily of the interest of this group, but I wanted to at least reference the fact that not only are we doing direct Skype-like, just person-to-person interaction, but we have these robust carts here that are located at each of our facilities that allow us to do things like look in the ears, the nose, the throat, look at the eye, look at wounds, listen to live streaming heart and lung sounds. Teleprimary care has become a huge component of our programs. Considering in our rural areas, it's very difficult to recruit MDs and DOs. So we essentially farm them in from other locations. Cleveland is actually also a hub location for providing teleprimary care services to other VAs in Ohio, Michigan, and Indiana. Currently are providing services out of our facility to Northern Indiana, to our Mansfield outpatient clinic, to our New Philadelphia outpatient clinic, to Saginaw, Michigan, and soon we're going to be opening up our doors to Cincinnati and Indianapolis as well. So not only are we doing this internal to ourselves, but we're doing it to a lot of others out there as well to help where they have need. Our program as a whole, forward a slide here. In fiscal year 19, which ran from October of 2018 until September of 2019, we had a strong goal. We really wanted to push specialty care expansion through our modalities outside even further than we have. We really wanted to increase the amount of services that we were offering. At that point in time, we had 40 plus active video telehealth program offerings. We had video to home that was deployed throughout primary care, mental health, and a number of specialty services. Our home telehealth program was growing for remote monitoring of chronic conditions, diabetes, heart failure, hypertension, substance use disorder, PTSD, schizophrenia, anxiety. There was a whole slew of, there were and are a whole slew of programs that were available within our home telehealth component, our retinal imaging and dermatology, and Storm Forward. And I really wanted to highlight last year specifically because of these two numbers. And you'll know why in a little bit. So last fiscal year, we treated over 17,000 patients via telehealth here in Cleveland for a total of over 69,000 telehealth visits in total. So a pretty large system. And I put that there because you'll see those numbers have been dwarfed based off of a lot of things that have happened recently that obviously all of you are very well aware of. Which would be COVID-19. So we had our plans, and we were in a great position, I felt, to really move forward and start pushing specialty care, really start being cutting edge in terms of looking at trends and data in terms of where we needed to have increased presence from some like Suboxone treatment or pulmonary or cardiology or infectious disease or GI. And then COVID-19 came and it completely derailed all of the plans that we had. Not in a bad way, but it really, the fact that we had a history really set us up in a good spot to be prepared for what was coming next. And that thing that came next was on March 3rd, when we received essentially from our national VA office a mandate, and most other healthcare institutions received something similar, that face-to-face clinics needed to shift to essentially an all telehealth mode, with phone, video, or some other form of electronic communication being standard to meet needs of patients out in the community. And that was a lot for us to kind of take in at one time, because although we're a large program in terms of volume, we're a pretty small group here in Cleveland in terms of manpower. So knowing that all of a sudden we were going to have those 17 locations of care and essentially every program within them under the sun receiving direct guidance from their national offices to switch over to these modalities, we were a little worried in terms of how we were going to be able to support that. And video to home is obviously the biggest push from all of that, because patients that are out there, telephone is great. There are reasons that obviously healthcare systems don't want to do everything via telephone because billing and whatnot. But more importantly, you really can't provide the patients with the care they need over the telephone. So VA Video Connect, which I referenced a little bit earlier, was obviously the primary mode that we were going to be sending all of this clinical support out to our patients. Then we were thrown another curveball, which I know a lot of you are well aware of, and that was the fact that VA Video Connect was no longer going to be the only approved method that we could use to provide care to our patients. And one of the big issues that the VA faced when COVID-19 first came out, when it came to video to home, and one of the reasons that when Health and Human Services released the memo that I'll reference in my next slide, was so important to us, was because the VA Video Connect platform I'd mentioned earlier is homegrown. And it had been used pretty widely, and you'll see some of our workload trends, but we were not technologically prepared for what was about to happen with COVID-19. And for the first 3 to 4 weeks of the real true COVID surge here in Cleveland, which started on or around March 11th, that platform kept crashing nationally. So our providers were unable to actually communicate with their patient via video. It was impossible at times. You could get into the platform at 8 o'clock Eastern Standard Time, but by 9 o'clock Eastern Standard Time, everything was dead in the water, because now you had Central and Mountain and some folks over on the West Coast starting to dial into that platform. And it really just maximized what we could offer, and the servers kept crashing. So there was the Health and Human Services memo that came out, which referenced that a handful of additional video to home platforms were going to be approved, at least for the interim, even those that may not be fully HIPAA compliant, for provision of actual healthcare. Anything that wasn't forward facing, like TikTok or Facebook Live or Instagram, anything that wasn't public facing that put the patient and the provider in a unique room that essentially could not be accessed by anybody outside of that, we were given the okay to use some of those platforms. Here in Cleveland, we suggested Skype for Business, which is different than the traditional Skype that's out there. We did that for a number of different reasons. The primary of which was just the fact that we were familiar with it here at our facility. It's something that's on all of our computers. It's something that's very easy for patients to use on their end. There's a free Skype for Business app they were able to download, and we could really police how the traffic was flowing from our building to the patient's devices in their home. And we were using that for not only video visits, but we were also using that for just patient and family interaction. I don't know if any of you, I wish I had the link prior to putting this together, but one of our veteran success stories, it was a recent discharge here in Cleveland 2 weeks ago. He was the first veteran to be discharged from our facility that came off a ventilator. And prior to his departure from our facility, we were able to not only have a surprise birthday party for him, but we were also able to connect his family into that surprise birthday party from all parts of the United States. He has family not only in Ohio, but also in Florida. And when he came around the corner, he saw all of his family members up on the screen, and it was a very touching moment. If any of you didn't see that story, it was a Rob Powers thing on Channel 5. I would suggest that you go out and watch it. It's very powerful and speaks volumes to the work that providers like yourselves and many others are doing at the moment to keep not only patients happy and healthy, but staff in the facilities as well. So I included not only this information for you, but also the Health and Human Services memo that you'll be able to open up. This way you can see the exact ruling in terms of programs that are okayed for use at the moment. Another thing that we had to consider here in Cleveland was Ryan Haight, obviously something that everyone is very familiar with on this call, I'm sure. The VA has always sort of had a little bit of a reprieve in Ryan Haight. But essentially, this was basically the law that indicated that unless there was a valid prescription and one in-person medical evaluation between the patient and the provider, you could not prescribe controlled substances via video. And that was a big worry for us when COVID-19 hit, because we have a lot of patients out there that we see in our Suboxone clinics and various other substance use clinics and our pain medicine clinics. And thankfully, we weren't the only ones thinking about that, because our national office got on the horn and was able to get some approval, essentially, which we'll go into in a little bit, to kind of relax some of the rules and regulations that we had here. But within the VA, our guidance when it comes to Ryan Haight, because of the high volume telehealth work that we do, is basically, if a patient falls into one of these two scenarios, you're okay to provide a controlled substance to that patient if you had not previously seen them in person. That's if they're being treated at a VA medical center or CBOC with a valid DEA registration by a PAC team or a specialty team, and the patient is physically located at that VA medical center. Or if the patient's being treated at a CBOC, and just for acronym purposes, that's community-based outpatient clinic. That's what we refer to our outpatient clinics as. Or if they were in the physical presence of another practitioner within the usual course of professional practice that had a valid DEA registration. So thankfully here in Cleveland, we were proactive about this years ago, and any facility that did not have an on-site physical pharmacy, maybe one that only had a Pyxis machine, we were able to get all of our facilities registered by the DEA. So any patient can go into one of our outpatient clinics and they can connect up with a medical provider who can provide them with a valid prescription for a controlled substance via video, even if they've never seen them in person. That is all well and good when patients are going into your buildings, but not when they're in their home. Previously, if the patient was not in a building, you could only prescribe that controlled substance to them via video to home if you'd previously seen them in person. So that was what I was referring to when I got into, thankfully, the VA changed some things, which we'll get into actually in 2 slides from now. But I'm not going to read through this slide here, but I wanted to at least give all of you the flow chart that we use here within VA to determine whether or not it is medically allowable for a provider to prescribe a controlled substance to a patient. So again, won't read through it, but it's there for you to review at a later date. The guidance that came out within VA in terms of video to home, it's similar to basically everything else. We're allowed to now, for the moment, we don't know how long this will go, and I think the most important here, controlled substances via an assessment conducted through telehealth for persons whom they have not conducted an in-person medical evaluation, if the prescription is issued for a legitimate medical purpose, blah, blah, blah. But as long as you can see and you can hear the patient, audio-visual, real-time, two-way interactive communication system, We are now okayed for the time being to prescribe those controlled substances via video to home without that prior first-person visit, which was very, very important for us because almost immediately out of those previously 13 outpatient clinics, only 5 of them had been open up until this past Monday. And in reality, most of them aren't opening back up until next Monday. And even that opening is going to be very soft and really only for essential patients that need to come in person. So now we're able to make sure that those veterans that do have that controlled substance need they don't have to come into our building for right now, not until things are safe. We can continue to provide them with the access to the care that they need with them in their home and keep them away from harm and not having to come into our building simply to get a medication refilled. So the actual outcome of a lot of this, I had referenced earlier in fiscal year 19, we saw 17,000 patients and of 69,000 encounters. This is our video workload at the moment here in Cleveland. This was as of the end of April. Because of the sudden surge of need, and you'll see how video to home directly impacted this, and there is a little bit of it right here as well. We just hit the middle point of our fiscal year in April, and we've already surpassed 17,000 patients seen this year. And we've surpassed 40,000 encounters completed through these telehealth modalities. And this has been right here, video telehealth to offsite patients. That's our video to home. That has been where the largest increase has taken place. And I'll get into a little bit of why we were so successful, specifically speaking to the substance use mental health group here in a moment. But you'll see a different number on the next page. This is our video to home encounter workload growth from a month-by-month trend here in Cleveland. So you'll see in October, we started with completing about 277 encounters, went up to 336, down to 320, 342, February hit 350, COVID came, 2,248 in March, April, and this isn't even full end of month figures yet because technically our providers have 7 days to close out encounters, and this was put together 2 days ago, 5,850 video to home encounters alone in April. That number will probably be closer to about 6,500 when it's all said and done. And like I said, pulled 2 days ago, we were already over 221 in May. From a patient standpoint, we've seen 4,386 this fiscal year, and you can see that growth trend is very similar when you go month by month. So it'll be about 300-400 patients or so we were able to treat in April alone. And that's unique patients. So each of those patients may have had visits with various different areas, which is why the encounter number is so much higher. So patients are seeing primary care, they're seeing mental health, they're seeing specialty. It's pretty impressive to see how we were able to come together and make that reality in such a short period of time. And speaking to mental health, we'll talk about them here in a brief moment. Here's our daily averages. You can see up until the point where we reached about March 14th. March 14th, we had one of our lowest periods of time, and I think that's because everybody was preparing. But you can see that growth just skyrocketing as we move forward. And one of the things that I find most impressive about this chart is we haven't even hit the point where I feel like we've hit capacity yet. I expect May and June and July growth to continue on the same trajectory that we're seeing here as people become more familiar, not only in our buildings, but outside of our buildings. From a mental health standpoint, and we'll talk a little bit in a moment about why I feel mental health works so well. You can see from our mental health groups, and these are a lot of the areas that do substance use treatment, pain medicine that does a lot of alternative modes of therapy and does a lot of Suboxone treatment in and of themselves. Mental health was pretty good in terms of feeling comfortable with this platform. That's a strong kudos to not only our mental health chiefs here, the pharmacists that are engaged within mental health, the frontline clinicians, but also the administrative staff. So although they had pretty significant growth between February, March, and April, you can see they were doing pretty impressive things right from the get-go. mind-blowing in a sense to see what they were able to do, at least to me as somebody who's worked in this for as long as I have. Why did it work? So mental health, I've felt for years, has always been ready for the new normal. They have a very proactive clinical and administrative training program for individuals that come into the building. 100% of all of our mental health provider staff that come into the Cleveland VA receive training on video to home and other telehealth platforms as a part of new employee orientation. 98% of our providers in that area are considered capable to do telemedicine at the moment, which is astounding. They have a long-standing history of actually doing it because the mental health world, medication management, PTSD treatments, various other alleyways and avenues, it's a perfect opportunity for something like video to home. They've had a huge clinic-based video program for years. They've allowed providers to telework, which we've found ways to get them connected up from home to home from home through video to home and back into our clinics. They're one of the service lines that don't look to me and my team to develop workflows and processes because they recognize that although, yeah, we're the technology experts here, I can't sit across the table from our psychology chief or our psychiatry chief or our social work chief or really any of their providers and tell them how to clinically use this tool or any of these tools. We can train them on how to use the tools, but how they use them in clinical practice is up to them. Their understanding of what's legal and what's not, who's responsible for what. They do have a willing patient population. They're flexible and recognize that technology won't always work. But more importantly, they recognize the need to have the technology available to everybody. So we've been working with them for years to ensure that all of their offices are outfitted. They know who to reach out to in the event that they do need something. And we're quick to react and make sure that when they have questions or needs, that those questions and needs get satisfied. Because we recognize that they're dealing with a very unique patient population that interruptions of care can be deadly. Some of the things that I feel are necessary behind the provider, which they do have within the mental health world. They have scheduling point of contacts who understand how to implement video to home or telemedicine and integrate it into their daily workflows. They have trainers that are embedded within their actual work groups. They understand who they're supposed to reach out to. Our facility telehealth coordinator, Rachel Overlander, when they have questions or problems, they can obviously always reach out to myself as well or any of our technology team members. And then they have a scheduling staff that works closely with providers to figure out how can this best fit your individual needs. So yes, a service line can come up with needs for the service, but the way that gets implemented into the daily workflow of each individual provider within the service is going to be a little bit different. Put some information in here for all of you in terms of at least video to home, because I do think that video to home is going to become sort of the new normal here within not only VA, but within the healthcare world. I just referenced a little bit earlier by Dr. Stream, I believe that this isn't going away anytime soon. So it's time to sort of stand up and figure out how to make this work. And this is a simple workflow that we put together here in Cleveland on how we can make it work from, the time the patient and the provider agree to a video to home visit, whether or not they're, a first time user, yes or no. And it just kind of works you through what it is that's necessary. And we just put together a new workflow yesterday that I'll be happy to share with the group that has a little bit more information as well. And I think more importantly than anything is when it works, there's amazing things that can happen when you do this. These are testaments that came in from patients who've used our platforms across the country. And I always put the first one up top, 86-year-old patient with progressive dementia and behavioral challenges. That patient was somebody that was able to get this technology to work for them. And as said earlier, I've been involved in this since 2006. And I've heard everything under the sun in terms of why things can't be done. Providers aren't comfortable. It's not the way we were trained. Our patient population is too elderly to really understand technology. And in some cases, that may be true, but the world is a different place than it was even 3 months ago right now. And this is an opportunity not only for the Cleveland VA and the VA Northeast Ohio healthcare system to really step up and change what's normal and move into the next phase of healthcare ready and prepared, but also for everybody on the outside. People are becoming more and more familiar with video conferencing technologies, unique and innovative ways to have meetings like this one. And once you open that door, it's going to be very difficult to close it because people aren't going to be comfortable for quite some time going out in public and interacting in large group settings. And even when comfort does become, a little bit more normal and we get back to the way, at least a little bit of the way that things were, once people recognize that they can get this type of care, whether it's mental health treatment or specialty care treatment or primary care treatment, once they realize they can do this from home and providers become more comfortable in what is safe and when you don't have to come in versus when you really kind of need to, people are going to want to be at home. And we have the tools available to us in VA. And I know that the Cleveland area in general, the Northeast Ohio area in general, is a healthcare hub. We should be very proud of the things that we get to do healthcare wise here, and we should be cutting edge. And I would love to see in a year or 2 years, that Cleveland, Northeast Ohio as a whole has really figured out a way to implement these types of things into regular everyday practice and didn't stop doing it when COVID-19 went away, because it's possible. And the future really is now. And I know it's kind of corny, but are you ready? Because I don't think a lot of us know what the new normal is, but the new normal is going to be something very different than February of 2020. So I would encourage people to do what our mental health offices, our pain management groups, our medicine services, our primary care offices here, what they did years ago that prepared them to handle what the task is today and what the task will be tomorrow and what the task will be a year from now. Because we were able to kind of build things up organically a long time ago, where when this hit, you saw in that growth chart, one little dip for a day, and then everything skyrocketed from there. I'm lucky to work with a great team here in Cleveland, one of which is on this call right now. And I'm very proud of the work that not only our group within Healthcare Technology Service did, but I'm blown away by what our providers and our nurses have been able to do with the technology that's been given to them. So I'm happy to be a resource to any of you on this call. I love talking with people outside of the VA. I sometimes get a little bit emotional when I actually talk about the work that we get to do here. But I know that healthcare has never been more important than it is right now. And anything that I can do to help you or your group, I'm more than happy to do it. I really appreciate the time that you've allowed me to speak to each of you. And if you have any questions now, or you have any questions tomorrow, or you have any questions 5 years from now, I'm more than happy to sit down and chat. Hopefully we can all do it in person at some point in time. But I also want to thank you for the work that you do, because you're the ones who are we're putting up all these signs that say heroes for heroes. But healthcare providers are really the true heroes right now. So it's an honor to be able to do a little bit, and I'd be happy to help you however I can.
Thank you, Dave. What a great presentation. A lot of insight here. I think we can open it up for questions. If anyone has any questions right now, I'll open it up.
David, it's Dave Stream from the clinic. I'm enrolling patients in my chart for my clinic patients has been a very positive experience for me. But one thing I've noticed is that a lot of them, there are the folks that you don't have to push, that are early adopters, and that's great. I find that a lot of patients who maybe are not early adopters. Maybe a good example is, I see a fair number of people who have, $500-600 smartphones where they answer emails and play Candy Crush and not much more than that. And in those situations, I really have to, as the healthcare provider, take the initiative to help the patient in a very direct way to get logged on, to download the necessary software and apps. And once I think they're willing to help to allow me to help them. And once I do get it set, they're very avid users of it because they see the value. But I wonder how many healthcare providers at the VA are as willing to spend, it's not a huge amount of time, but it is some time, and how accepting are the patients of letting their doctor or their nurse help them with their smartphone versus, the folks in, whose responsibilities are more focused on the healthcare technology interaction with the patients. I'm just interested in your perspective on folks that are more in your area and focused on healthcare technology versus the clinicians, and how well the clinicians accept that and how well the patients accept. Do you see an advantage of one over the other in scaling this?
Yeah. So here in Cleveland, we were very adamant to our leadership group years ago that this is not something that providers should be, for lack of a better word, wasting time on. You're all very busy people. You have a lot of things to do. So we went to our front office and said, look, if we're going to make telehealth or video to home or whatever it may be, what it can be, we need the resources to be able to support the providers out there. So we don't ask our providers locally to do any of those things that you were just referring to. Obviously, they're more than welcome to, and we provide many, many different training sessions to large groups, to small groups. But we encourage providers to actually pass that patient over to us. We created an administrative consult within our electronic medical record system that's called a video to home equipment request and education request. And all that we ask of the providers, regardless of what provider type they are, is to just have that initial conversation with the patient up front. Is this something you're willing to try with us? If the answer is yes, and the provider wants to help the patient right then and there, great. They've already been trained on how to do that. If they don't have time to, or if they don't feel comfortable in doing that, we tell the patient, you're going to put in this referral to our group. We receive hundreds of consults a week right now that are simply for us to give the veteran a phone call, talk to them about what equipment they have in their home. If they don't have something that can operate our platform, we can order them an iPad that'll come preloaded, not only with what they need to complete their video visit from a virtual medical room standpoint, but they also come preloaded with Verizon or T-Mobile data packages. So the veteran also doesn't have a cost associated, they don't have a cost associated with the tablet that we provide or with their actual data plan. So we distribute a lot of equipment, but more so we distribute a lot of education. And the amount of consult referral growth that we've seen dwarfs the actual workload that you saw on some of the slides a little bit earlier. So I'm not overly familiar with how the Cleveland Clinic administratively operates its telemedicine programs, but I don't think individuals like you or the other providers on the call should be responsible for the stand-up of the actual technology. I think that's where we can play a very solid role. And as long as there's bandwidth to accommodate the need that's out there and the growth that we are currently seeing, which thankfully we had, that wasn't by luck, that was by design. I think it can work very well, because you can have an 85-year-old veteran who's perfectly capable of doing it, but may need an hour on the phone figuring out how to do it. And I would rather we spend that hour on the phone with that veteran than you have to spend even 10 minutes in your office, because when the vet's there, or I need to stop saying veteran and start saying patient when I'm talking to non-VA individuals, but when the patient's there in the room with you, you have better things to do. So as long as you have that initial conversation as the provider with the patient, so we know when they call them, they're not asking, who are you again? And still some of them do, because they are elderly in cases. I think there is a perfect marriage in that sense. The provider is responsible for the initial notification of the patient. We'll take the education part of it on ourselves. And then that consult workflow works beautifully, because then the provider also gets alerted when that patient has completed a successful test call with us. So they know that that individual is not only capable of doing it, but they have done it.
Great, wonderful, thanks.
You're welcome. All right. Well, like I said, I encourage, if any of you have questions at a later date or time, feel free to give me a call. Feel free to shoot me an email. I'm more than happy to help out.